for his talk. Dr. Vijay Negalur is a well-known person in the field of diabetes. He is a leading diabetologist of the country. And he has a vast clinical experience as well as the research experience. And he has various publications to his credit. He has various awards to his credits. And without wasting much of the time, I will request Dr. Vijay Negalur, sir, to proceed with his talk. Welcome.
Thank you, Amit. Thank you, Dr. Balchi Sabu, for the kind invitation. And I'll share my screen now.
Yes, sir, please.
Yeah. So my talk is 20 years of evolving therapeutic targets in the diabetes management, how it has changed over the last 20 years. Now we have seen here, the initial part of diabetes management was only question of survival. And that time we had only insulin available. As we advanced, the next thing that we had in our mind is to prevention of complication of diabetes, and that we had therapeutic options like insulin, the diet modification, and of course the oral drugs. As we progressed ahead, we have now 2000 to 2020 is the prevention reversal of complications and reversal of diabetes also, the good quality of life and complete life experiences that we expect for the patient to have. And for that, we have insulin analogs, the advanced drugs in diabetes and CGM. And the future will be looking at genetic underplay, etiopathogenesis cure, and of course, the stem cell therapy, personalized medicine, enzymes in telemedicine, all that we're going to discuss in short. So this is the evolution of pathophysiology of diabetes, which has progressed over a period of time. And we have done from triumvirate to quadrate, the quintet, the septate, sextate, and the ominous octet, and now we have deadly dozen. And we have progressed again in the understanding of diabetes and its various facets of diabetes. So we have now diabetes, which was like this in the past when the TVs were fat and the man was thin, and now life has changed. This has become the other way around. The TVs have become thin, but the man has become fat and has developed so many complications of insulin resistance, the metabolic syndrome, the coagulation, inflammation, the lipid abnormalities, and the weight, so on and so forth. So the past era was that of glycemic lowering therapy. And we have this all-cause mortality versus intensive therapy of glucose lowering. We saw that most of the studies did not show any benefit in terms of cardiovascular outcomes. So current approaches fail to reduce mortality in patients with diabetes. You take an example, for example, you have UKPDA as the advanced, the VADT and record. Look at the VADT, 6.9 versus 8.4. This can never be taken as the good way of trial. But we have patients who are in the control arm of 8.4 A1C, whereas those who received intensive treatment were 6.9. But what did we see? This was a maximum difference of 1.5 A1C that we have seen. And with all this, there is no change in the primary outcome. There is no change in the death from a cardiovascular outcome. Also, there was any small difference in the reduction of microvascular complications that we see some 18 or 20 patients who reduced microalbuminuria in the VADT trial. So that is what we have observed with intensive glucose therapy. The follow-up of all these studies, whether it's accordion, advance on, or a VADT follow-up, none of them have shown any benefit. None of them have shown any legacy effect anywhere, despite of the intensive glycemic control. So therefore we doubt whether it's legacy or a legend in these patients. The intensive glucose treatment, the meta-analysis, have not shown any benefit. There's no reduction in the MACE, hypos and weight gain was a concern, and some reduction in the microvascular complication was seen, otherwise no benefit. So we had these drugs, 5 drugs in the few 70 years. Now in the last 12 years, we have 25 drugs, but we know the story of rosiglitazone, which brought in the industry to have the study for the cardiovascular safety. And therefore the safety became the predominant outcome of all the studies versus the efficacy that we used to do in the past. So the efficacy used to look at the benefit of therapy, and we used to see number needed to treat, but now we look at no harm to be done. So we look at number needed to harm. So there's difference, and this is what the FDA wants, and this is what the new studies are. So with that in mind, these studies came into picture. From 2008, more than 190,000 patients have been enrolled in the various outcome trials. And we know these are the various trials right up to the SOUL trial, which is semaglutide in the by oral route in patients of cardiovascular risk prevention. So these are the various trials that we have from the year 2007 till 2024, and the first of that kind is a DPP-4 inhibitors, which it looks at the CVOT outcome, and you see almost all the studies have not shown any superiority in the outcome. And if you look at the hazard ratio, for example, for a heart failure, the saxagliptin showed increased risk of 27% with a p-value of 0.007. The examined study also showed a similar trend, though the p-value was not significant, and the TCOS and Carmelina were neutral from that point of view, and Carmelina showed some 10% reduction without a significant p-value. So this is the story of DPP-4 inhibitors, which did not show any cardiovascular superiority. In fact, few of the drugs showed increased incidence of heart failure in patients of diabetes. So after the years of frustration, finally, some good news has come. And these are the various studies which have really revolutionized the treatment of patients of diabetes management. Looking at GLP receptor agonists, there are the 8 trials which are listed up here. And if you look at the MACE outcome, the 4 of these trials, for example, the leader, the SUSTAIN, the HARMONY, and REWIND showed some kind of a benefit in kind of MACE. If we look at the death by cardiovascular disease in the GLP analogs, leader trial showed a significant of almost about 22% benefit, and you have p-value of 0.007, which is highly significant. If we look at stroke in the GLP receptor agonist, it was only the SUSTAIN trial and the REWIND trial which showed a good response in the stroke by GLP therapy. This is probably because these drugs reduced blood pressure significantly. So the reduction in the hypertension probably is responsible for such a beneficial effect of the GLP receptor agonist in terms of stroke outcome. If you look at the kidney as an outcome in these trials, especially the leader and SUSTAIN, again, you see all the benefits in both the leader trial and the SUSTAIN trial, all the points before the line of unity, except for the renal death, the point was beyond the line of unity. Otherwise, by and large, both these drugs have shown some kind of renal benefit as well. So first time we have seen the molecule which had the cardiovascular benefit, especially the atherosclerotic benefit, and also the renal benefit in this study. The first of its class as an oral drugs in GLP was also now approved by US FDA, which is again a semaglutide, and this has an availability of less than 1%. It has a special type of absorption enhancer called SNAC, and it is 1% of the drug is only absorbed. Now the study is also underway, SOUL study, determining its effect on heart disease. So this is again a special kind of technology which helps these proteins to get absorbed in the GI tract. Now we have the new kids on the block, the SGLT2 inhibitors, and these have been great drugs because when it was presented in 2015 at Sweden, Stockholm, at the EASD meeting, the excitement was so much that people continuously started clapping after listening to this particular trial. And you look at any outcome, primary outcome, death from any cause, death from a cardiovascular disease, and of course the hospitalization heart failure, which reduced almost by 35%. So just significant first time results showing the cardiovascular benefit really brought so much of enthusiasm in the minds of doctors and the patient alike. So we know that the heart failure is pretty common. 3 out of 10 patients have heart failure, and it's 2 to 3%, and it is 2.5 times much more common in patients of diabetes to develop heart failure. And when you have heart failure, you lose your life by 4.6 years, and those compared to 4.6 years compared to those without heart failure, it is just 3.5 years. So therefore, there's a significant loss of survival. So there's 2 studies, DAPA heart failure and the EMPEROR reduced. You look at the DAPA heart failure, the worsening of heart failure, the hospitalization of heart failure, the cardiovascular death, hospital heart failure, or CV death, the total hospital heart failure, and the CV death, all of them show significant reduction, 26%, 30%, 18%. So very, very significant. And the interesting point of this is the patients included in the study had also no diabetes. So diabetes or no diabetes got the best benefit. Same is true with EMPEROR trial. The heart failure is reduced by 25%, first and recurrent by 30%, and slope of decline was reduced by 50% in GFR. So therefore, these are the benefits you see in patients, both diabetes and non-diabetic patients. So this was explained very elegantly by Milton Packer in the last EAST meeting, which was again a virtual meeting, which said that the accumulation of all the glucose and lipid intermediates is responsible for decrease in SIRT1 and AMPK, and that is the one which suppresses autophagy and increases the AKT and mTOR pathway. And what the SGLT2 does, it decreases these activation of the autophagy, which is very important part, and relieves the oxidative stress, and of course the dysfunction of other organelles and inflammation. With that, you get excess sertraline and excess AMPK and reduction of the AKT and mTOR pathway. This how it slows the development of cardiac disorder in patients of diabetes, and that's where you get the benefit. Now, how do we know this? What are the biomarkers that you need to test this? So one is the uric acid decrease that you see in patients when they get DPP, when they get SGLT2. There is increased ketogenesis in these patients when they get this therapy, and of course the hematocrit rise. All of them suggest that there's increased amount of PGC1 alpha and FGF21 and the heart failure 2 alpha. All these are reduced, and therefore you get the beneficial effect of this drug in patients of heart failure. Now that's the story of SGLT2 in heart failure. This is the article written by Deepak Bhatt in Cell Metabolism. And what he says is the foundation of therapy is the ARNI, is the ACE inhibitor ARBs, MRA, the beta blockers, and now the dapagliflozin, and of course empagliflozin. So what was initially a heart failure prevention, now is heart failure treatment, where the patient has diabetes or no diabetes. This is the offer, this is we can offer them. Look at the kidney benefits, whether it is CKD or a DKD. The Credence trial, of course, has shown the benefit, but this only included type 2 diabetic patients. It showed all the benefits in the kidney impairment. And patients of DAPA-CKD trial, which was released in 2020, had patients with or without diabetes. The eGFR as less as 25 to 75 again showed a good benefit in terms of almost 50% reduction in the renal outcome. And the study which is awaited is EMPA kidney, which has a GFR almost 20, as low as 20, and will probably show the same benefit which the Credence and the DAPA-CKD showed. So this is how the 2016 guidelines and societies have been recommended the SGLT inhibitors and GLP receptor agonists for the treatment for the CRM benefits, the cardio-renal metabolic benefits. And we know that in 2015, we only looked at glycemic control. In 2016, we have CV mortality benefit. In 2018, the atherosclerotic cardiovascular disease and chronic heart failure benefit. And in 2019, some nephroprotection and chronic kidney disease and DKD. And 2020, we have independent of A1C, atherosclerotic cardiovascular disease, heart failure, and chronic kidney disease, all of them showing the benefits. So you don't have to have diabetes to get these benefits. Even without diabetes, also you get similar benefits. So therefore, Merlin Thomas, the professor of medicine, Department of Diabetes at Monash University, Melbourne, Australia, said that SGLT2 inhibitors have written a love letter to the kidneys straight from the heart. So that's how this story of the heart and the kidney tied together by the SGLT2, giving benefits at both the ends. As we progress ahead, the history of insulin also has shown a progress from 1910 right up to 2017, when we had a lot of newer insulins have coming. The Ideglira improved, the fast-acting insulin, Glargine 300, and a once-weekly insulin. We had discussion in the previous session about a once-weekly insulin injections. So this is again also improvement in the insulin analogs. The flatter insulin and also very rapid-acting insulin both have shown equal improvement. Talking about the basal insulin, we have seen that we have progressed from the NPH insulin that was first discovered by Hagedorn. Then we had the first generation of the basal insulin, that is Euglargine 100, then Euglargine 300, and we have Degludec 100, Degludec 300, which has a profound and a long-term action with this particular drug. Now we have this BRIGHT study, which first head-to-head randomized controlled trial, and it looked at hypoglycemia anytime and nocturnal hypoglycemia. What is striking is in the initial titration phase, the Degludec has higher incidence of hypoglycemia, both anytime and also predominantly in the nocturnal hypoglycemia. both had shown a higher incidence in patients who were taking degludec. So the BRIGHT was the first direct comparison, and during the full study, the maintenance periods, anytime nocturnal confirmed hypoglycemia is higher in patients who used the degludec compared to glargine. So that was the study, and very important in the titration phase, because quite often the patient gives up the taking therapy during titration phase. And nocturnal hypoglycemia is also very important because most of us witness the patient of death in bed syndrome because of hypoglycemia occurring at night, because there is no sympathetic drive, there's only parasympathetic drive occurring. The microbiome also has come in a big way. The unbalanced microbiome is responsible for the change in the microflora in the intestine. The fecal transplants have been shown to improve the insulin resistance. Some Chinese study looked at it, and there's a French study which is now looking at the increasing microbiome diversity to improve type 2 diabetes. So it's again a new feather in the cap. So this is the later development that we see. This is what was taught to us in the bedside medicine. Then we have patient-centered care. Then we have team approach with multiple people putting the heads together. Now we have a lot of guidelines telling us how to treat. There's also a precision medicine which is coming in a big way. And that is again through the internet, taking into the artificial intelligence, which is how we are using to treat this patient. So personalized medicine is also come as a big emerging approach to disease treatment and prevention that takes into account variability of a gene. And these are the neonatal diabetes, the congenital hyperinsulinemia, MODY, all these diseases are being treated with this in mind. So the artificial intelligence is also using decision support system, using robotics and independent decision maker. In the absence of clinician, the patient can get the benefit of this independent decision maker, and therefore the patient can get all the benefits which are possible, especially when the rising incidence of diabetes and paucity of doctors. This has made a great change in the patients managing diabetes. And a lot of studies have shown that a doctor following the patient showing a lesser response compared to the artificial intelligence using to control the patient's diabetes. So to end my talk, ladies and gentlemen, what I said so far in the last 20 minutes is the modern medical advances have helped millions of people live longer, healthier lives, and we all these improvements were decades of investment in the medical research. With that, I thank you very much for